Well, good morning. It's a pleasure to be here to speak to you about the use of MRI imaging in the electrophysiology laboratory. We started looking into MRI as a guiding imaging modality for electrophysiology procedures because we feel that fluoroscopy has some disadvantages. Certainly, the advantages of fluoroscopy are that it provides familiar views and landmarks for catheter positioning, and we're all used to knowing how to advance catheters through the aortic valve or to appropriate positions in the right atrium and right ventricle for our electrophysiology studies using the cardiac silhouette on fluoroscopy. But the disadvantage is that there's a lot of ionizing radiation, and fluoroscopy lacks soft tissue resolution. So when we have catheters advancing into the heart, we don't know if there's aortic stenosis when our catheter buckles at the aortic valve, and we don't know how thin the right atrial appendage or the right ventricular apex is when we're pushing or one of our fellows is pushing those catheters into place. So certainly having the soft tissue resolution to see the tissue characteristics would be extremely helpful to us. MRI, compared to fluoroscopy, offers superior soft tissue resolution. It has no ionizing radiation. It can provide us with real-time three-dimensional imaging without the need for image registration, and it can also show us scar and potentially lesions and depth of lesions as we apply them. The first issue that we have to tackle if we want to make MRI usable for the EP laboratory is its applicability to patients with implantable devices, since a great majority of our patients currently have devices when they present for catheter ablation. As you know, the presence of permanent pacemakers and defibrillators is a contraindication to performing magnetic resonance imaging. We started this by looking at a series of patients that were referred to our institution for a clinically necessary imaging study. In the initial study, we had 68 patients enrolled. We did 56% of patients with pacemakers and 44% with defibrillators. We noticed no symptoms consistent with device movement, torque, or heating. There was no inappropriate inhibition of pacing, and there was no unexpected or rapid activation of pacing. And after the MRI, both at acute and chronic follow-up, we saw no changes in device parameters. Since that time, we've had the opportunity to scan over 430 patients, 550 scans, and what we found is that now we have the power to detect very small changes in lead parameters, although these changes are so small that they don't truly affect device function, and in no single case have we had to reprogram the device to deal with these changes. They're on the order of less than 1 millivolt for sensing in the right ventricle and less than 0.1 volt for capture threshold at a fixed pulse width. Artifacts are something that we have to deal with when doing cardiac imaging, especially on steady-state free precession imaging sequences. We can see susceptibility artifacts related to the device generator and also related to the leads. But by selecting imaging planes perpendicular to the plane of the generator, shortening the echo time, or using different sequences such as spin echo and fast spin echo MRI sequences, we can reduce the amount of artifacts and get quite acceptable image quality. Some examples that hopefully you'll be able to see along with this talk include this image of a patient with a transposition of great vessels, which is very adequate for merging with an EP navigation system or for hopefully real-time use, and also an image of delayed enhancement showing some septal scar in the setting of non-ischemic cardiomyopathy. In order to perform these procedures in real time, we set up a system that includes a non-magnetic filter box to reject the 64 megahertz imaging frequency, an amplifier module, a converter to digitize the amplifier output, a fiber optic link to the data acquisition computer, a stimulation unit to provide pacing, and catheters which have no ferromagnetic materials. They have woven Dacron bodies and copper wires and platinum electrodes. We measured temperatures at the tip and ring electrodes in 5-second increments for many different permutations in catheter shape and position, and we found that the temperature rise was very limited, on average around 2 degrees C more at the tip than at the ring, but certainly within a safe clinical range. We looked at the electrophysiology signals in the scanner. Unprocessed, these signals can have quite a bit of radiofrequency and electromagnetic interference noise. However, if you apply filtering, you can significantly improve the signal-to-noise ratio and have signals clean enough to see small potentials such as delayed potentials or His potential as shown in one of the images on this talk. We also showed the feasibility of atrial and ventricular pacing with capture of the myocardium in the CMR scanner during a scan. Importantly, we can visualize lesions, and the visualization of lesions actually predicts the physiology. So in this image you can see if we pace at the epicardium and sense, it takes 20 milliseconds for the signal to travel to the sense electrode. When we fill the gap with a lesion, that time doubles, showing that the image can predict conduction block. After doing this preliminary work, we then brought 2 patients to the lab where we performed real-time imaging to look at the navigation of a catheter into the right atrium and to the cava tricuspid isthmus. These patients had typical flutter ablation in the lab prior to this procedure. We were able to navigate the catheter in real time and to visualize the cava tricuspid isthmus and also to record electrograms in these patients. We have looked into the CMR physiology correlations and found that if patients with non-ischemic cardiomyopathy have more than 25% wall thickness scar, that predicts inducibility of ventricular tachycardia. The EP study, this can be a powerful tool for risk stratification. And also, we found that the location of scar in imaging is consistent with the morphology of VT that's induced at EP study, confirming that there's a relation between the scar that we image and physiology and the VT induced in the laboratory. In the cases of VT ablation that we've done with concurrent MR imaging, we can see that an extensive surface map does correlate to sites of scar on imaging. In this example, epicardial mapping was performed for a patient with 4 different morphologies of VT. I've shown one of the VT morphologies and a pace map that goes along with it in this slide. And if you look at the correlation of this with the CMR image that was obtained after the catheter ablation, we can see that the MR image actually provides much greater detail than the electroanatomic voltage mapping. So the availability of this type of information would certainly be very useful during the procedure, at least reducing the procedure time and finding the scar, but also providing a greater amount of detail in terms of the depth of the myocardium, because the electroanatomic image, the voltage map, only gives us a surface surrogate of what the scar is, and no information about what is in the depth of the myocardium. In this image you can see transmural scar, white, in the inferior and lateral aspects of the left ventricle, and heterogeneous tissue in the interseptal region, and that's where one of the VTs in this patient was inducible. If you compare side by side the MR image to gross pathology, you can see that the MR image actually carries a lot more information compared to the gross pathology. The lesion is visualized on gross pathology, but the MR image shows quite a bit of detail in terms of the scar architecture and the depth of tissue. So in conclusion, CMR is capable of characterizing the substrate identified via detailed EP studies, and incorporation of adjunctive information from CMR into EP studies could reduce procedure times, and it could provide information regarding the substrate deep to the surface being mapped, and we hope that this can greatly help with our procedures.